on inspection, so of trachea, so trachea, if it is shifted towards the same side, then you can think about the fibrosis of lung. And as the trachea is shifted towards the opposite side, so that is because of the empyema, or it might be because of the effusion. Okay, so effusion, if it is infected, that is known as the empyema. Okay, so that's empyema. Your terms are बिस्तारै तिमीले सिक्दै जान्छौ है, so on the coming days. And if it is decreased unilateral chest expansion, okay, so if you examine the chest on the expansion हेर्ने चाहिँ कसरी भने मेजरिङ टेप लिने, मेजरिङ टेप लिएर के तिम्रो चाहिँ उसमा निप्पलको लेभलमा, so if you measure it, okay, so measure it, then ask the patient to take deep breath. Okay, so deep breath, त्यसले कति डिफरेन्स आउँछ कि हैन, सो कति एक्सपान्ड हुन्छ. सो नर्मल एक्सपान्सन इज मेनली 5 to 7 हैन, 5 to 7 इज नर्मल एक्सपान्सन. सो इफ इज युनिल्याटरल के डिक्रिज मात्रै छ भने द्याट्स इम्पाइमा थोरेसिस सम्झिनु पर्यो हैन. इफ द डिक्रिज बाइलेटरल चेस्ट एक्सपान्सन, देन यु क्यान थिङ्क अबाउट द इम्फाइसिमा एन्ड द इन्टरस्टिशियल लङ डिजिज अर आस्थमा. ओके, सो दिज आर द सर्टेन थिङ्स द्याट यु आर गोइङ टु डु इन द क्लिनिकल एक्जामिनेसन. क्लिनिकल एक्जामिनेसनमा बिस्तारै गर्दै जान्छौँ एन्ड द्याट विल नो हैन. अब अहिले नातिहाल्यो के हो भनेर हैन. सो द्याट विल मेनली टिच यु इन द क्लिनिकल मेथड्स. ओके, सो द्याट्स द क्लिनिकल मेथड्स. त्यो चाहिँ अलिकति पढ हैन, यो भने यो चिज पढ्नु पर्दो रहेछ भनेर चाहिँ इज इम्पोर्टेन्ट फर द्याट हैन. सो द्याट्स वाइ यु हेभ टु फलो द 2 books हैन. सो डेभिडसन एन्ड म्याक्लोवर्ड्स हैन. सो म्याक्लोवर्ड फर योर क्लिनिकल मेथड्स एन्ड देन द योर टेक्स्ट बुक इज मेनली डेभिडसन. अब होइन अलि धेरै पढ्नमा लागेको छ भने यु क्यान गो अप टु ह्यारिसन हैन. त्यसमा अहिले चाहिँ डेभिडसनलाई चाहिँ के एज अ मूल मन्त्र सम्झ. And then it's mainly then you are going to in the percussion and palpation पछि percussion आउँछ. Percussion मा चाहिँ you will do the percussion. In this there might be a dullness or there might be a hyperresonance. So dullness छ भने fluid हुनु पर्यो या कि consolidation हुनु पर्यो कि collapse हुनु पर्यो हैन, consolidation हुनु पर्यो. Hyperresonance छ भने हावामा hyperresonant हुन्छ हैन. So that's mainly in case of तिम्रो चाहिँ pneumothorax. Otherwise our all areas will be resonant until and unless there is a lever at the fifth intercostal space, right? So that will going to tell you in mainly in the clinical methods and clinical classes. Then coming to the auscultation, the another step is auscultation while you are going to examine. So in the first you are always say about the breath sound. Breath sound, normal breath sound is a vesicular breath sound. In vesicular breath sound, what happens is that your inspiration and expiration, there will be no gap, but the expiration is always shorter than the inspiration. And after breathing here, and after breathing here, लामो सास लियो छोड्दाखेरि के हुन्छ हैन, एक्सपिरेसन त्यो लामो सास लिएको भन्दा थोरै हुन्छ हैन. भनेपछि normal is a vesicular breath sound, and the another is a bronchial breath sound, in which the inspiration and the expiration will be equal and there will be a gap. So that's not a normal breath sound, so that's a abnormal breath sound. So we're going to get the bronchial breath sound in case of pneumonia and other causes like cavities. Okay, so cavities, thick wall cavities, that you are going to get the bronchial breath sound. And then early inspiratory crackles is mainly in case of chronic bronchitis. You can get the wheezing. Okay, and mid inspiratory crackles in bronchiectasis, late inspiratory crackles in the interstitial lung disease. Okay, so crackles you can hear even in case of interstitial disease, or it can be because of the alveolar collection of the fluid. Okay, so that's mainly the issue that we are going to hear in the auscultatory finding in the chest examination. So coming to the what are the things that you are going to look is the mainly the another added sounds is the wheeze. So fixed monophonic wheeze in the endobronchial mass, and then the random monophonic wheeze. Okay, so if there is a fixed obstruction is there, then there will be always a one phonation. So you can think this may be a fixed obstruction, that is might be because of the obstruction like endobronchial mass or any foreign bodies, that can be a possibility. And then the random monophonic wheeze in case of asthma, expiratory polyphonic wheeze in case of emphysema, sequential inspiratory wheeze in pulmonary fibrosis, decreased vocal resonance. Another is a vocal resonance. That is. So in this, what तिमीले के गर्छौ भने भन्दाखेरि auscultation गर्दाखेरि stethoscope ले तिमीले चेस्टमा राख्यो, चेस्टमा राखिसकेपछि you will ask the patient to say 1 2 3 1 2 3 1 2 3. Okay, so if you are thinking if you are hearing the sound is coming from the earpiece and कानमै आएर बोलेको छ भने that you think this is the increased vocal resonance. यदि तिम्रो चाहिँ त्यो डायफ्राम हुन्छ नि, स्टेथोस्कोपको डायफ्राम थाहा छ नि हैन, गोलो भएको त्यो चाहिँ त्यहाँबाट भन्दा नि टाढाबाट आएको छ भने चाहिँ that is a decreased vocal resonance हैन. तिमीलाई चाहिँ त्यो बोल्दाखेरि त्यहाँबाट भन्दा नि टाढाबाट आएको छ भने that is known as a decreased vocal resonance. So these are the terms things that you are going to look. अब यही हेरेर नै तिमीले चाहिँ सर्टेन चेस्टको डायग्नोसिस गर्ने हो हैन. So that's the clinical method. So that's the clinical method that we will going to teach you in the clinical postings. Okay, clinical postings. And I say decreased vocal resonance in case of emphysema and pulmonary fibrosis. त्यो हैन, त्यो सोच्नु पर्यो. अब चेस्ट एक्जामिनेसनमा अरु हेर्ने भनेको चाहिँ you can go for the cardiac examination. In cardiac examination you can go for the heart sound. Okay, so heart sound left ventricular failure ma bhayo bhane these are the sounds that you are going to see. S1, S3, that is Caleb rhythm, the left ventricular failure. Okay, so these are the things that you are going to hear in the examination finding. So diagnostic clues के छ भने अब विज आयो, डिस्निया आयो, एलर्जी छ, नक्सुलर कफ ट्रिगर्ड बाई एक्सरसाइज अर कोल्ड छ भने यू क्यान थिंक अबाउट द आस्थमा. पोस्ट नेजल ड्रिप छ, साइनोसाइटिस छ, राइनोरिया छ, नेजल कन्जेसन छ भने अपर एयरवे हैन कफ सिन्ड्रोम अर यूएससीएस अर पोस्ट नेजल ड्रिप सिन्ड्रोम भनेर सम्झिनु पर्यो हैन. पोस्ट नेजल ड्रिप छ, साइनोसाइटिस छ. देन इफ द पेशेन्ट गिव्स यु द हिस्ट्री अफ हार्टबर्न. ओके, सो छाती पोलिरहेको छ, मलाई त एकदम अमिलो पानी आइरहेछ हैन, त्यसले गर्दाखेरि मेरो स्वर पनि अलिकति घस्रो भयो के वर्सनेस जस्तो भइरहेछ हैन, वर्सनिङ के थोत्रो स्वर आइरहेछ, वर्सनिङ होइन लाइङ डाउन अर बेन्डिङ छ भने चाहिँ यू क्यान थिंक दिस माइट बी अ जीआरडी. ओके, सो ग्यास्ट्रोइसोफेजियल रिफ्लक्स डिजिज. लो ग्रेड हैन फिभर हैन, सो एभर वाज है लो ग्रेड फिभर, नाइट स्वेट्स, वेट लस हैन छ भने देन यू क्यान हेमोपाइसिस छ भने क्यान बी अ पल्मोनरी ट्युबरकुलोसिस. दैट विल गिभ यु द क्लू. इफ द पेशेन्ट अफ द ओल्ड एज, क्रोनिक स्मोकर छ, वेट लस भइरहेछ, हेमोपाइसिस छ भने then you can think it might be a lung cancer. Okay, so this is how you are going to make the differential diagnosis. And so differential diagnosis त्यसरी एप्रोच गर्दै जाने हो. And then अब तिमीले examination पेशेन्टको examination गर्दाखेरि क्लबिङ पायो. If there is a clubbing is there is a copious amount of prudent sputum छ, postural variation छ भने bronchiectasis, that will give you the clue. And then smoker is there, early morning clear or mucous sputum production छ भने then you can think okay, I am dealing with a chronic bronchitis is the another one. And then if there is a decreased hemoglobin अब अर्को let's see. And so now so these are the diagnostic tools. Now investigations, you can go for the complete blood count, and so complete blood count will give certain clues like if it is decreased hemoglobin because of the persistent hemoptysis and because of the loss of appetite and decreased intake, the patient can have a decreased hemoglobin in case of lung cancer. Increased hemoglobin in case of COPD. Why there is increased hemoglobin in COPD? COPD मा increased hemoglobin किन हुन्छ? Anyone can answer? What happens in COPD? The oxygen is going to be less. Okay, so what happens if there is a hypoxia? Why there is going to be increased hemoglobin? किन हुन्छ होला?
Erythropoiesis brought, sir. Erythropoiesis.
So erythropoietin secretion will be there. Okay, so that's why. So that is known as a secondary polycythemia. Okay, so if the patient is having a hypoxia and then the erythropoietin is going to be produced more, so by the GC cells, and भनेपछि अनि त्यहाँबाट तिम्रो चाहिँ patient will have a polycythemia. Okay, so polycythemia is one of the complication of COPD. Right? So that's a important thing. Okay, यदि polycythemia भयो भने हामीले domiciliary oxygen दिनुपर्ने हुन्छ हैन, पेशेन्टलाई oxygen therapy गर्नुपर्ने भयो, and then even the patient has to go for the phlebotomy. Okay, so blood getting down to decrease the hemoglobin. Otherwise, there is a high chance of having a pulmonary embolism, DVT, so coronary artery disease, or even the stroke is going to happen if there is an increased hemoglobin. Then coming to the eosinophilia, so eosinophilia is the another thing that will give you the diagnosis like non-asthmatic eosinophilic bronchitis. Okay, so that's the another one. And then chest X-ray to detect structural cause of lung disease. CT chest, if abnormal, chest X-ray needs further imaging. that is important. So if the abnormal chest x-ray छ भने मात्रै सिटी चेस्ट गर्ने हो हैन, कफमा हैन, अनि सबै गर्ने भनेर सबै चिज गर्दिने हैन। पहिला चेस्ट एक्सरे गर्ने, चेस्ट एक्सरेमा केही देखिएन, केही देखियो भने then only we are going to look for the CT chest. Okay, that's the needs of further imaging. And sinus imaging and nasopharyngoscopy to diagnose upper airway cough syndrome. No, but it is not routinely done. Okay, so but if the history is suggestive of sinusitis, pansinusitis, you can go for the sinus imaging in the form of the X-rays and X-ray. If it is required, then the ENT people will definitely go for the nasopharyngoscopy or CT scan of the sinuses. Okay, so that's the thing that you are going to do. So this is the X-rays, and so X-ray you can see on this side. So there's a opacity. Normal X-ray is like lung field should be like this. So translucent. So there's a opacity is there in the upper lobe. So mainly the pulmonary upper lobe involvement. So there's mainly opacity. You can see the opacity is shadow. So in case of pulmonary tuberculosis, so this is a CT scan. So the radiology is allied in the medicine. अब रेडियोलोजीको के फोर्थ इयरमा क्लासै हुन्छ, so they will teach you all these things. Okay, so this is the typical things of the bronchiectasis. Okay, so you can see this. So this is just like this section of the chest, and यसरी काट्यो. Okay, and so you can see this bronchus. Okay, so bronchus is dilated. Okay, so permanent dilatation and destruction of the bronchus is known as a bronchiectasis. So definition ma त्यही त हो नि, भनेपछि यो सबै destruction भएको छ हैन, destruction, and it is producing a signet ring like appearance. Okay, so this is the thing that we are going to see in the bronchiectasis in case of CT scan. And the pulmonary and interstitial fibrosis or ILD. Okay, so interstitial fibrosis, even case of the post-COVID fibrosis, all these you are looking is a mainly interstitial fibrosis. Can you see this? So all these are the fibrosis, okay, with underlying honeycombing appearance like a bronchiectasis fibrosis along with. So these are the interstitial lung disease and CT scan. Lung carcinoma, X-ray CT scan, you can see a big mass-like thing. Okay, so mass-like thing which is mainly enhanced. So that's mainly a lung carcinoma. And the another is the investigation that you are going to do in the respiratory is a spirometry. And spirometry ma obstructive pattern with reversible also there salbutamol or any bronchodilator after inhalation, the your FEV1 has increased more than 12%. So that will come in the asthma lecture on the next lecture. Okay, then it is known as asthma. And if it is irreversible, but you can only get in the obstructive pattern, that is COPD. And if it is a restrictive pattern, then it can be an interstitial lung disease. So interstitial lung disease means sarcoidosis. So that is mainly a granulomatous cause of the ILD. So that we'll discuss on the ILD lecture. Okay, so restrictive pattern. And the bronchoprovocation test and methylene challenge test is also done in case of asthma, but ideally it is not done. So I'll also discuss this in the asthma class in this lecture. Then the investigations that you can going to do is a sputum cytologema. Eosinophilia in non-asthmatic eosinophilic bronchitis, malignancy, sputum for AFP, and for if AFP is negative, and then still you are suspecting is mainly a tuberculosis, then now the test is gene expert. Even in case of sputum positive, now they have advised to do the gene expert, because gene expert will give you the whether you are dealing with a resistant organism or not. Okay, so we will mainly see in the gene expert is the rifampicin resistant, and while for the isoniazid resistant, you are going to do the line probe assay. And now I'll go detailedly on the lecture of the pulmonary tuberculosis on this. Okay, so gene expert and line probe assay, and what are our national new guidelines of DOTS for the treatment of tuberculosis that I am going to detail on case of in the class of pulmonary tuberculosis. Then the sputum for KOS mount in case of blastomycosis or any aspergillosis, you can do that. Okay, so in case of KOS mount, our indication of bronchoscopy is mainly a red flag signs or sputum induction for cell count and different cell count is needed. And so bronchoscopy saying red flag signs are weight loss or hemoptysis. Then if you are thinking about a tumor, then only that you are going to do. Okay, on that. So this is the indication of the bronchoscopy. Then to complete the list, So you can do for the GRD को लागि यो गर्न सकिन्छ 24 hour pH impedance monitoring most likely के gastroenterology को लेक्चरमा यो हुन्छ होला GRD मा हैन तिमीलाई might be next lecture मा के डाक्टर सीताराम or डाक्टर मुकेश might deal on this. So 24 hour pH impedance, high resolution monitometry, barium shallow and video के fluoroscopic evaluation, endoscopy, and so these are the things that you can do to complete the investigation of the reflux disease. Then cardiac assessment, if you are thinking of the cardiac, then you can go for the ECG, echocardiography, okay, so that you can go for that to rule out whether you are dealing with the left ventricular failure or left ventricular pathology for causing the pulmonary edema. So these are the things that you are going to complete the list, okay. So now coming to the breathlessness. So breathlessness, also known as a dyspnea in the medical term, is defined as the feeling of an uncomfortable need to breathe, okay, and it is unusual among the sensation, and it is, has no defined receptors, no polarized representation in the brain. So mainly the thing is that it might be efferent or efferent receptors which taking the sensation towards the respiratory center, and that's why patient will have a breathlessness. And multiple causes both in health, exercise, and in disease of the lungs, heart, or muscles is the mainly responsible for the breathlessness. So this is the picture which is nicely given in your Davidson. Okay, so this will give the respiratory stimuli contributing to breathlessness. And whenever there is a lot of causes which are causing the breathlessness. Just like so from starting from here, so there is a pulmonary fibrosis, or there is there. Okay, so it will increase the your respiratory drive, right? So respiratory drive. So increased mechanical load is there, and there is a receptor out here, and that it will this spinal efference brings the sensation towards the respiratory center. Okay, so respiratory center, and patient will have a feeling of breathlessness on this. Similarly, if the patient has any bronchial disease, okay, so airway obstruction like asthma or emphysema is there, okay, then it also causes the increased mechanical load if there is obstruction, and this pathway will get activated. Okay, so there is JC receptors or anything out there in the chest wall, and so your receptor so it might, you might have read in your basic science, and so this will carry the sensation out here, and the patient will have a sensation of breathlessness. And similarly, what happens in the airway obstruction because of the hypoxia, the patient will have an increased pent-up collection of the carbon dioxide. Okay, so carbon dioxide will be there, and it causes the acidosis, that is known as a type 2 respiratory failure. So what happens if the partial pressure of carbon dioxide is going to increase? So the another chemoreceptor is out there in the central chemoreceptors, and then it will there is a decrease. What happens in the acidosis? So the pH is going to decrease, so increased CSF, this will be activated, and this also activate your respiratory centers. Okay, so that's the another one. And then the similarly, if the case of the pulmonary embolism, the same thing is going to happen. Okay, so there is mainly a increase amount of mechanical load is there, and there's a vagal lung efference that will carry the sensation to the respiratory centers and all these things. And then the another is because of the hypoxemia, that is a altered ventilation and perfusion mismatch is going to happen in the case of pulmonary embolism. So I'll come to detail on the pulmonary embolism class or respiratory failure classes on this. Okay, so altered PQ mismatch. So with this, so there is what is happening. There's the increased PSU2 and PaO2, and the chemoreceptors in the carotid body is mainly active with this, and this again carried out this sensation towards the medulla and the respiratory center, and the patient will have a breathlessness. And so this is the good graphical thing that is explaining you about the stimuli contributing to breathlessness. So what are the causes of the breathlessness? So always, so these are the important questions. So this is one of the great questions for you. Right? So you see your condition, so breathlessness so everyone is going to ask about what is the cause of the breathlessness, and then according to that you will going to approach. Right? So if always divide into the system. So cardiovascular cause, acute dyspnea is mainly acute pulmonary edema. Okay, and then In the respiratory cause is acute severe asthma, so most common, C6 one is the most common. Then the acute exacerbation of COPD, so this is also from your book, Davidson. Pneumothorax, always think about pneumothorax. Okay, so if the patient तिमीलाई बसिरहेछ जहिले पनि इमर्जेन्सीमा 2 घण्टादेखि एकदम श्वास भएर आइरहेछ भनेपछि pneumothorax is the one of the medical emergency. Okay, so if you are not diagnosing pneumothorax, you are going to lose the patient. Pneumothorax, pneumonia, and then the another is a pulmonary embolism. So pulmonary embolism को लागि certain risk factor हुनु पर्यो हैन जस्तो अब अहिले कोभिड भएको पेशेन्ट आयो तिमीलाई कोभिड भयो डाक्टर साहब मलाई त कोभिड के 2 हप्ता अगाडि भएको थियो के मलाई एकदम श्वास हुन थाल्यो अब इभन 2 हप्ता हैन इभन आफ्टर के वी आर गेटिङ आफ्टर के 6 weeks के 2 months and so the patient with pulmonary embolism after the COVID. And so it is very thrombogenic, this COVID. So that's why you are going to think about the pulmonary embolism. The pulmonary embolism to COVID भएको छ यसलाई हैन अब if the more common in the patient with the patient who is mainly coming with the के तिम्रो चाहिँ immobilization हैन immobilization भएको छ जस्तै अब patient is coming from तिम्रो चाहिँ US बाट आइराछ अहिले हैन US बाट आए के तिम्रो चाहिँ घर आइपुग्यो तर अब राति घरमा he has developed then के shortness of breath and किन long flight छ हैन के leg swelling को history पनि छ भनेपछि there might be a formation of DVT on that patient and that might have embolized, right? So you have to think about that. So these are the important things that you have to think. And अब कोही bedridden patient छ घरमा त्यो patient even in the hospital bedridden छ भने if the patient develop the acute shortness of breath, always think about the pulmonary embolism on that background. And the another is the ARDS, inhaled foreign body, lobar collapse, and laryngeal edema. So these are the for the complicated leaks. So only the respiratory and cardiovascular system is not only responsible for the acute dyspnea. So there are certain metabolic causes like the patient of diabetic ketoacidosis. Okay, so DKA. So acidosis is there. So in case of metabolic acidosis, in case of lactic acidosis, in case of CKD patient, that patient have a metabolic acidosis, and overdose of salicylates, ethylene glycol poisoning. Okay, so alcohol, ethylene glycol poisoning. All these causes the high anion gap metabolic acidosis. Okay, so that will be mostly dealt in your nephrology class in the acid-base balance. Okay, so in the metabolic acidosis, the patient can present with acute shortness of breath. Okay, and the psychogenic hyperventilation. In this group of patient, you can find the chest will be absolutely normal, but you are seeing the patient is having a hyperventilating. Okay, so hyperventilating. So you have to think about these causes. Then the patient, if the another important question that always being asked about the what is causes for the chronic exertional dyspnea or progressive shortness of breath. Okay, so you have to think about certain causes. If the patient presents with the chronic, progressive for days and months, then you can think about for months and weeks. So it's a chronic shortness of breath. So it's because of cardiovascular is chronic heart failure. So there's a lot of causes of chronic heart failure. So heart failure lecture now will deal on that. And then the myocardial ischemia. Okay, so that might be a act as an angina equivalent. And then in case of respiratory, COPD, chronic asthma, lung cancer, ILD, the patient presents progressive breathlessness in which there is a sarcoidosis, fibrosing alveolitis, extrinsic alveolitis, pneumoconiosis, chronic pulmonary thromboembolism. Okay, so the embolus which is being thrown out frequently, and chronic pulmonary CTTA, chronic thromboembolic phenomenon is there, and lymphocytic carcinoma is mainly in case of carcinoma. Okay, carcinoma in that, and large biliary effusions. In case of severe anemia, obesity, okay, decongestion, and severe anemia बिर्सिनु भयो कुनै पनि पेशेन्ट क्रोनिक एक्सर्सनल डिस्निया डक्टर माता भरानी उभिरहेको नि एकदम श्वासमा भइरहेछ नि सबभन्दा कमन चिज फिमेल अझ फिमेल हैन सो फिमेल व्हिच इज के मेन्स्ट्रुएटिङ फिमेल प्रेजेन्ट विथ के तिम्रो सर्टनेस अफ ब्रेथ भनेपछि सबभन्दा पहिला सुरु हाम्रो दिमागमै के जानु पर्यो भने इट्स माइट बी अ सिभियर एनिमिया बिकज अफ द मेन्स्ट्रुएसन बिकज अफ द मेनोरेजिया हैन सो पेशेन्ट माइट हेभ अ एक्सेसिभ के लस of the blood, and because of that the patient is anemic, right? So त्यसले गर्दाखेरि चाहिँ shortness of breath भयो कि भनेर सोच्नु पर्यो, हैन? So these are the things that how you are going to to approach the breathlessness. And then the another is the clinical features in the acute breathlessness. Mainly a pulmonary edema the patient can have a chest patient can present with chest pain, palpitation, orthopnea, or cardiac history. And so you can find the central cyanosis, increased JVP, sweating, cold extremities. Then you can find the increased size of the cardiac shadow in case of chest X-ray. Cardiomegaly will be there. You can have pulmonary edema will be there. Pulmonary pleural effusion can be there. ABG गर्यो भने दुईटै gases PaCO2 र PaO2. PaCO2 किन बढी घट्छ भन्दाखेरि because of the hyperventilation. Okay, so because of the hyperventilation, the PaCO2 is washed out. So you can find that. Massive pulmonary embolism, there should be a risk factor भने जस्तै immobilization भयो, recent surgeries भयो, and there might be other genetic factors like polycythemia भइहाल्यो हैन, अब factor 5 factor leading factors कम भयो भने हैन. So all these are the certain risk factors of the massive pulmonary embolism that you have to think about. Patient can have a cyanosis, हैन, so cyanosis will be there, and the patient can present with hemodynamic compromise like shock and tachycardia, hypertension also. And then there might be certain excess changes that might be certain signs. Okay, so prominent highlight vessels and there are also the size, and you can say the sinus tachycardia in ECG. All these are the findings you are going to get in the massive pulmonary thromboembolism. And the acute severe asthma, history of asthma can be there. Patient can have tachycardia, pulses paradox, and then the hyperinflation will be there. Of COPD, previous smoker, sinuses, hyperinflation. So there are certain signs of the COPD that will come on the COPD lectures. Okay, so what are the signs? You go and read the first 2 pages of your Davidson. Okay, so there is a pictorial findings there. Clinical finding. So that will be very helpful for you. So helpful for you. So these are the important. And pneumonia, metabolic acidosis, and psychogenic things. So these are the important things that you are going to get on the your findings. So findings in the clinical features of acute breathlessness in the certain group of patients. Then the another term that you always breathlessness we will say is a progressive. Okay, and कति progress गरेछ पहिलाको भन्दा हैन, that is known as a modified medical research council breathlessness scale. So this is given in both books हैन. हिस्ट्री लिँदाखेरि यो लिनु पर्यो हैन. सो भनेपछि अब डाक्टर मलाई पहिला हिँड्दाखेरि मलाई एकदम धेरै एक्सरसाइज गर्दाखेरि एकदम उकालो चढ्दाखेरि मात्रै श्वास हुन्थ्यो भने मात्रै भयो भने त्यो चाहिँ तिम्रो चाहिँ ग्रेड 1 भयो हैन. सो ग्रेड 1 भयो. तर अब तिम्रो चाहिँ आफ्नो पियरसँग हिँड्दाखेरि पनि मलाई श्वास भइरहेछ नि ग्रेड 2 भयो हैन. ग्रेड 3 भने चाहिँ म 100 मिटर हिँड्दाखेरि पनि गाह्रो भइरहेछ ग्रेड 4 हैन. सो दिस अगेन हेज बीन नोटिफाइड एज द 4A 4B. And so that you can read in your McLeod and the Davidson. So you have to ask about in the history of the MMRC breathlessness scale. And then another 2 terms that you should know in the breathlessness is the orthopnea and paroxysmal nocturnal dyspnea. And orthopnea भने चाहिँ so patient cannot lie flat at all हैन. बिरामीले डाक्टर म त उतार्न परेर सुत्न सक्दिन हैन, मलाई त जहिले सुत्दाखेरि 2-3 वटा तकिया चाहिन्छ भने, so that's known as orthopnea. So orthopnea even can be because of most common in case of cardiovascular, or it can also happen in the respiratory disease. And so respiratory disease because किनभने respiratory disease मा के हुन्छ भने तिम्रो चाहिँ यदि सुत्दाखेरि के हुन्छ, what happens to diaphragm? Diaphragm comes up. Okay, so if there is a vital capacity is decreased in the patient, like just like ILD, even case of emphysema, हैन, त्यसमा vital capacity कम हुन्छ. So झन् अब diaphragm माथि आएपछि तिम्रो chest को capacity is going to decrease, and that's why the patient will become breathless. And another is a paroxysmal nocturnal dyspnea. PND भने चाहिँ के हो भने the patient will not able to will go absolutely fine while he is going he or she goes to bed, हैन, केही problems. And after 2 to 3 hours of the sleep, patient has to wake up because of shortness of breath, and they have to go to the window to have a fresh air. होइन. सो त्यो भनेपछि द्याट इज नोन एज अ पिएनडी. सो पिएनडी चाहिँ मेनली किन हुन्छ भने है इज बिकज अफ द लेफ्ट भेन्ट्रिकुलर डिजिज. ओके, सो इफ द पेसेन्ट, इफ यु आर गोइङ टु गेट द हिस्ट्री अफ पिएनडी, देन अलवेज यु हेभ टु थिङ्क द्याट यु आर डेलिङ विथ द पेसेन्ट विथ अ लेफ्ट हार्ट डिजिज होइन. सो त्यो चाहिँ सम्झिनु पऱ्यो होइन. सो भनेपछि द मोस्ट इम्पोर्टेन्ट थिङ टु डिफ्रेन्सिएट बिट्विन द कार्डियक डिस्निया एन्ड द रेस्पिरेटरी डिस्निया इज द्याट if the, you are finding the patient with a history of paroxysmal nocturnal dyspnea, so then you are thinking that it might be because of the cardiac dyspnea. Okay, so it's mainly because of the cardiac cause than the respiratory cause. Okay, and the mainly the dyspnea is more common than the cough in case of okay चाहिँ तिम्रो चाहिँ उसमा कार्डियक कजमा होइन. सो मेनली whenever there is a pulmonary congestion only, then the patient will have a cough because of the cardiac cause. Okay, so that's why, so these are the important findings to differentiate between, how to differentiate between cardiac dyspnea and then the respiratory dyspnea is another important question that you can get in any okay, vivas or lecture in the case presentation. And so that's the question, and that you have to differentiate between twos. And so these are the terms that you should know about the breathlessness. So with this I am going to conclude. So read about the approach to the breathlessness. And so breathlessness को approach तुमको के respiratory मा पनि दिएको छ, and you can also open up your the critical illness को topic मा पनि दिएको छ हैन, Davidson हैन. So you can read on that, and the cough you can read in the McRate and उसमा पढ हैन. सो दिस इज हाउ यु आर गोइङ टु एप्रोच है. अब यही चिज नै यु आर गोइङ टु एप्लाई इन द क्लिनिकल प्र्याक्टिस हैन. सो क्लिनिकल प्र्याक्टिसमा एप्लाई गर्छु. सो इन नेक्स्ट लेक्चर आई एम गोइङ टु डेल विथ द एयरवे डिजिज हैन. सो एयरवे डिजिज वी आर गोइङ टु स्टार्ट अन द विथ द अस्थमा. सो यु क्यान रिड द्याट बिफोर कमिङ टु द लेक्चर्स. सो एनी क्वेसन्स इज देयर यु क्यान आस्क मी हैन. टाइम त छ हैन, तर मैले धेरै टाइम लिएँ आज because I have to cover up the two topics हैन. त्यही भएर केही छ क्वेसन? कहाँबाट पढ्ने त बुझ्यौ नि हैन, कहाँबाट पढ्ने बुझ्यौ नि. सो दिस अ फर्स्ट लेक्चर हैन, अलिकति उ भएको जस्तो लाग्छ. नाउ इट्स बेटर यु शुड ओपन अप योर के फर्स्ट के 3 पेजेस अफ योर के डेभिडसन हैन. डेभिडसन